if you come to my home, even in my garden, there are multiple Digilog devices which I have tied on the trees and on the plants, because on Sundays I will try to experiment in my garden how to fix that branch with that main branch or something like that. There are certain papers which have been published by oral maxillofacial surgeons that says that the half-life of 60 Vicryl in nasal cavity is 65 to 70 days, because the process is very complicated. It's a long journey, a legal journey, and intellectual journey, then experiments, failures, then cadaveric trials.
Yes, sir. So we see that from various illustrative complications you have listed behind using this biopins or screws for fixing those osteochondral fragments, there are a lot of arthritis being built up in those young adolescent populations. So we need to know, like, what motivated you behind developing and refining this suturing techniques for fixing those osteochondral fragments, and your journey behind designing this DG log.
Thanks, Satish. Actually, when all my colleagues started sharing their cases with me, I used to call them and ask them, what were the challenges. And I found out that the most common challenges was first the confidence, whether there will be any compression of the fragment with the sutures or not. The second challenge was that whether the needle will pass, because it is very difficult to pass the needle with the thick subchondral bone of patella, and there was chances of getting fragmentation. The third challenge was it is always a surprise when you try to fix the osteochondral fracture. You have to innovate or customize, because patella is a concavo-convex bone, and these pieces come out from the periphery, from medial part or from the apex. So it is difficult to have a fixed method, and they used to customize this in every cases. So I realized that if I can devise an implant which is like standardized for any type of osteochondral fracture, if we have a step-by-step guideline to fix it, then it will be easy for the surgeons to fix it. So with that idea, I started designing or experimenting on various things. First, we started on wooden boards, then we came on sponges. We used different materials of different thickness and density to mimic the cartilage, to mimic the subchondral bone, and to mimic subchondral spongiosa. Then we tried different needles which can, work and penetrate easily. And then finally we freeze two designs. But the beauty of this was the ring, the protection ring. We named it as DG ring. The beauty of the protection ring was that it served multiple purposes. The first purpose was that it allowed the forces to spread centrifugally. So the forces spreads in all the direction and help in compression. The second beauty was that because of the ring, there was uniform compression on the osteochondral fragment on the native bed. So when you pull it from the anterior surface or tight on the anterior surface of patella, all the suture ring will push the osteochondral fragment on its native bed. So there was like the centrifugal forces were getting converted into the compressive forces. The third advantage was that, you have heard about the cheese wire effect. The patellar cartilage is very thin, and if you tight too much, the vicryl or the polygalactin can cut through and causes the fragmentation of the fragment. So the beauty of the suture ring or the protection ring was that it kept the sutures elevated. Say, for example, this is the suture ring. It will keep the suture elevated on top of it rather than on the bottom of it. So with that, even though there was a compression with the sutures remain little bit elevated away from the osteochondral fracture. And the fourth advantage of suturing was that only one central hole of 2 millimeter drill is required. Just one 2 millimeter drill bit from the center. All peripheral 4 needles or the 4 holes are required outside the osteochondral fragment in the crater of the bone. So in the tiny fragment, you just need one drill hole. The other things, the protection ring will spread the forces and will allow it to provide the compression. But after that, the next challenge was the strength, because we were worried how much a polygalactin can provide the strength. So we need to do the biomechanical testing. And once we did the biomechanical testing across various models, and we tried 15 models in different directions, And I'm happy to share that the minimum strength which we got was 140 Newton. It went on till 240 Newton, but the 140 Newton was the minimum strength, which is a good enough strength for fixing of the tiny osteochondral fractures. So this is the final design which we came across. If you can see, there is a central pilot needle which will pass through the central 2 millimeter drill hole. Then there are four threads which are following it, which leads to ultimately a suture ring or DG ring. And that suture ring, once it placed on the osteochondral fragment, it gets, it has four peripheral sutures with four peripheral needles, which goes from the periphery of the fragment. And all the bunch of four sutures and four peripheral sutures comes out on anterior surface of patella, where you can, tie them and fix the osteochondral fragment.
Wonderful, sir. It's a very thoughtful innovation, we must say. In your practice, what is the timeline for the absorption of sutures, sir?
Because that question I have been asked over 100 times in last 20 years. Standard Ethicon Johnson & Johnson website says that Vicryl 10, or sorry, Vicryl 30 or 40 has a half-life of 45 to 60 days. There are certain papers which have been published by oral maxillofacial surgeons that says that the half-life of 60 Vicryl in nasal cavity is 65 to 70 days. And there is another paper which says that half-life of 60 polyglactin in oral cavity is again 64 to 70 days. So roughly, if we talk about 60 or 70, the half-life is around 2 months or more than that. What we use is Vicryl number 1 over here, or polyglactin number 1 here. So there are no literature search available so far. I actually tried extensive search to find out. So there are no literature available for number 1 polyglactin at present. But based on the data of 60 and 70, I believe that it will not be getting absorbed before 2 months. And since these patellar osteochondral fractures are in adolescent age group, which has a faster healing potential, the fracture heals in 3 to 4 weeks. In all my cases, 20 years I had been following the cases. In 3 to 4 weeks, patient is absolutely pain-free with full range of movement. And even examining the patient, that fracture is healed. Even though in all my cases, I'm getting MRI done at 6 to 8 weeks to be doubly sure, but it heals before that.
So thank you for that answer, which everyone would be asking behind you once you describe this technique, sir. So that's wonderful. So as you said, there is a need for standardization in the technique, and you clearly showed how it has to be done. Can you also visually give us any video on how it could be done as a practical implementation of this DG lock in a fracture? Is it possible, sir, with the video?
Yeah, sure. I can show you a video. So now you can see there's a female, I think 21 years old. She has an osteochondral fracture from medial patellar facet. And as you can see, when I'm pushing the patella is getting dislocated. The piece which we retried was around 12 by 14 millimeter in size, which was from medial patellar facet. So I did medial patellar arthrotomy, everted the patella, prepared the fracture bed, curated all the blood and fibrous tissue from it, and put the fracture fragment back into its space. You might need to do some drill holes in some of the cases if it is little bit old or there is some fibrous tissue, or you can just scoop it and scrap it. So the idea is to make the fracture surface raw. Then you want to put the fracture fragment back into its space, its anatomic location, and a single towel clamp is needed to hold it in situ. Now you open the DG lock device. There is a pilot needle which carries 4 sutures as its tail. So you take out the pilot needle first and keep all other sutures in the packet, because you do not want to injure yourself or your assistant with the needles. So just using the pilot needle, which is here, and you can see the suturing is there, which is movable. Sometimes you want to put a fixation knot to, have a fixation point till how much you want the central needle to go. But otherwise, in newer version, this fixation knot is coming pre-prepared. So you don't need to do that now anymore. So now after that, you drill a single 2 millimeter drill hole from the center of the osteochondral fragment, and that should come out on the anterior surface of patella, right? Keep your assistant holding the osteochondral fragment with the towel clip. Remember, it will be little tough to drill because it is the thick subchondral bone. Then pass the pilot needle from the central hole or pilot hole all the way and come out on the anterior surface of patella till the knot which you had just put in comes it or rest on the osteochondral piece. Now create 4 peripheral drill holes in 4 diverse directions, not passing through the osteochondral fragment, but passing through the periphery of the osteochondral fragment, actually in the crater or at the junction, whatever is convenient to you. And then keep on passing the needles, the peripheral needles from each peripheral hole, and all the needles should come out on anterior surface of patella. So you can see I have passed 2 peripheral needles and sutures from the 2 craters, and now I'm making the 3rd peripheral hole outside the crater, outside the osteochondral fragment, into the crater or at the junction, whatever is convenient in that particular case. Once that drill has been done, I'm passing the 3rd peripheral suture from the peripheral hole, which comes out on the anterior surface of patella. So remember, when you tie the knot, you should tie the knot in the diverse direction or the sutures in the diverse direction. Sometimes the fragment is small and a little bit crumpling of the DG ring takes place, but it is fine. It depends on the size of the fragment versus the size of DG ring. Now, when all your sutures have come out on anterior surface, tie any central suture with any peripheral suture. So see, that is the beauty of the device. It is not that you have to match each suture, each central suture with its corresponding peripheral suture. Any central suture is good enough with any peripheral suture, and just tie whatever kind of knot you like to put and keep on tying. So first tie 2 diverse knots on an anterior surface, then put another 2 diverse knots and tie them on anterior surface of patella. In this case, I had tied first and then I drilled the 4th drill hole, but you can have all the drill holes done together and then tie the knots together. Now, as you can see, there is little bit crumpling of the DG ring here because the size of the fragment and the DG ring had little bit mismatch, but that is fine. What you should do is, while placing the 4th suture, you should little bit spread it, and then it will be nice to have a good compressive strength on the patellar osteochondral surface. You put it back. In this case, if you can see, there is a superficial quad graft which has already been harvested, so that I'm going to fix it after the surgery. But before that, put the fragment back, do multiple range of movements so you are sure that your polyglactin ring is holding the fragment nicely. Then open it back and check it back. If there is some displacement or something has occurred, check for the stability of the osteochondral fragment. And once you are satisfied that it is holding back and providing good strength, it is good to go. You do MPFL reconstruction and then you do arthroscopy again and check for the tracking. And you can see that osteochondral fragment is very well placed into the defect, and the DG ring is very well holding the fragment at its base. And now I'm trying to push the patella laterally out of the trochlea, but because MPFL reconstruction has also been done, patella is not dislocating. So this is the case when it is a first time dislocator with osteochondral piece. You should do both the techniques simultaneously so that patient do not have a recurrence later on. The fracture unites, and because MPFL reconstruction has been done, it doesn't dislocate again.
Okay, sir, that is a very illustrative video showing the technique to make it in a very standardized fashion. And I have few queries from this, sir. So, like, what is the diameter of the needle, like the 4 prongs of the needle that you are putting in on the peripheries? Like, is really 2 mm drill bit really necessary, or we can go lesser on the size?
So the standard which I recommend is 1.9 millimeter diameter for the central hole, because it carries 4 polyglactin 1 number sutures behind it, right?
Okay.
So 4 polyglactin suture has to pass through that. So minimum 1.9 millimeter. But for practical purpose, it is difficult to have 1.9 millimeter drill bit in everybody's surgical armamentarium, but 2 millimeter drill bit is universal and everybody has got it. So I say that if you can have 2 millimeter drill bit, it is fine. No need for 1.9 mm. And for the peripheral hole, we have found out that 1.2 millimeter drill bit is good enough because again, it has a polygalactin suture which follows the needle. And if you have a lesser diameter, then you can, cause the little bit shredding of the polygalactin suture material. So in the center hole, I'll recommend 2 mm. In the peripheral hole, I'll recommend 1.2 mm. And if you don't have 1.2 mm, 1 mm drill bit is good enough, but you need to be a little bit careful with that.
Thank you, sir. So the next follow-up question on that is, like you were saying that you need to put a anchoring knot before you put in the central wire, right? So central loop. So is the purpose of the knot is to overhang the DG ring so that it doesn't come in flush with the cartilage surface? Is that the purpose of it?
Exactly. That is the purpose. So we call it as fixation knot or fixation node. The purpose is that first, once you put that node and put all the 4 sutures from the anterior surface of patella, it will help in holding the fragment in its place. And second thing is, because it is little bit proud, it will keep the DG ring also proud, and it will prevent the cheese wiring effect at the central hole. Otherwise, cheese wiring effect will take place at the center of the hole. So that is the idea of putting that knot there.
How is the rehab protocol for this particular technique, sir? Is it same as that of biopins or any other type of fixation? Do you start mobilizing early or?
I'm little aggressive in all my cases because I feel, and in all my cases I've seen that it provides a very good compressive strength at the fracture fragment site. So I start movement from day 1. And depending upon tolerance of the patient, I aim to get full movement in 1 to 2 weeks time. 7 to 14 days is the target which I give to my physiotherapist and my patient. And I encourage them to get full movement by that time. I start full weight bearing from day 1 with brace locked in 0-0 position. I remove the walker because initially I keep them with walker, but I continue with the brace in patellar osteochondral fracture, the AKBK brace or the full length brace for 3 weeks, and then I give them hinge knee brace after 3 weeks. If the fragment is small, if the fragment was really big, then in that case I continue with walking brace for 6 weeks. But full weight bearing is allowed from day 1 with 0-0 lock, and movements are encouraged from day 1.
Have you
Thanks.
had instances of doing follow-up MRIs? How is the healing in such cases?
Yeah, if I can show you some MRI. So this is the patient which I just show you the video of surgical video. This 2 months follow-up MRI, and you can see that there is interference screw in from the medial side of femur that is for MPFL reconstruction. And if you look at patella, there is widespread bone marrow edema because we had put 5 drill holes in patella. So the subchondral edema is obvious. But if you look at cartilage, there is a healthy cartilage which is homogeneous and which is consistent in consistency with the surrounding cartilage, and it is well healing. There is a good bone-to-bone healing which is seen, and there is good cartilage which is like homogeneous with the surrounding cartilage, isotense with surrounding cartilage, which is indicative that it has survived. Now, if the same patient, if you look from clinically, then there is a stable patella you can see at 2 months follow-up. Patella is not jutting out, and there's full range of movement at 2 months. And even if you look coronal MRI in this case, you can see multiple drill holes in the central image and bone marrow edema, but there is a good bone-to-bone union. And the same patient, when you follow for 1 year follow-up, still the MPFL reconstruction screw is seen, but there is complete resolution of edema because 1 year has passed. The bone-to-bone healing is obvious. The cartilage has healed well and survived, and the substance of cartilage is isotense and homogeneous as compared to the surrounding cartilage, which is indicative that it has healed as hyaline cartilage, and there is no loss of cartilage in this case, which is also evident on sagittal view images. So I get this MRI because I'm a little bit, curious to understand the process. So usually my pattern is that I get MRI between 6 to 8 weeks to be sure that everything is going fine, even if I'm, confident clinically. And then 1 year follow-up to see that, okay, everything is done. Now patient and me both can forget the pathology.
Okay, sir, that's wonderful. So to see this healing of fragments, it's very rewarding that the procedure has worked well, and the patient is also very happy that they forget that such an incident has happened in their life.
Yeah, true.
So,
I agree.
In your case series, like, did you had or encountered any complications out of this technique or the device or for the pathology per se that you want to correct or you want to advance it further, or it needs any refinement in its process?
So the major challenge that I have seen is that uh, that same technique, when there is a patellar dislocation, the osteochondral fracture can come from infero-medial part of medial patellar facet or apex. But sometimes there is a chip fracture from lateral trochlear margin also. Now, that's where the challenge is because lateral trochlear margin is chip fracture cannot be fixed as easily as in patella because the straight long needles, they can go anywhere on the posterior part or posterolateral part of the knee and can damage any structure. So whenever there was a lateral trochlear osteochondral fracture, I always feel little bit skeptical that probably this device may not be working for that pathology. And to solve that problem, we did another cadaveric, experiment, and we came out that if we use curved needles for fixation of osteochondral fracture in lateral trochlear margins, then it's easy. So now a new version is being planned where a lateral trochlear margin osteochondral fracture will have same digilog device, but it will have curved needle which will come out on lateral gutter rather than coming posteriorly. So when those curved needle will come out from lateral gutter and we can tie the knots on the lateral surface of lateral condyle, and probably that can solve the problem.
So this is an excellent scientific presentation, sir. How did the process start? Did you do a prototype in your hospital and then take it to the company? Did they do the regulation part and patenting, or did you do it all the way alone?
That's a very good question. And to be honest, it's not easy. It's not easy for a clinician. It's not easy for a surgeon because the process is very complicated. It's a long journey, a legal journey, and intellectual journey, then experiments, failures, then cadaveric trials, and then first you try on plastic models, then on cadavers, then legal permission, and then government approvals. So it's a long, long journey. It's not easy. I will thank the Healthium MedTech Private Limited from Bangalore. They are very, very nice people, and they are always promoting the innovators. So I must say that the company was a big help for me because when I shared the idea with them, they said that they will help me to uh, come out with the idea on paper, then on models, and then they will help me through the journey. Uh, what we went was that first we discussed the idea on paper, then we checked the feasibility, whether it is feasible to make such an implant or not. And believe me, for almost this took me from the agreement to the first model. It took me 2 years, and in that 2 years, 1.5 year was spent on in a wrong direction. 1.5 years we were struggling to find a solution for a problem which actually did not exist. And after 18 months, we realized that, we are hunting for a problem for which we don't need a solution. We are in a wrong direction. And as soon as we changed the direction, within the half an hour, the problem was solved. So I think probably it's a destiny that your mind has to get wired properly. Your mind and the mind of your colleagues who are helping you to develop the product. But it took us 18 months to wire it properly and align with each other. But as soon as we got aligned with each other, in the same sitting, in 15 minutes, we were done. That okay, no, not this way, and it's easy. If you look at the implant, it's very very simple implant. 4 threads of wire with a suturing, nothing more than that. But that was the beauty because we wanted the implant to be as simple as possible, as user friendly as possible. At the same time, it should be as versatile as possible, and it should allow a uniform standardized technique. So yes, the journey was really very exciting. We tried on various cardboard models. If you come to my home, Even in my garden, there are multiple Digilog devices which I have tied on the trees and on the plants, because on Sundays I will try to experiment in my garden how to fix that branch with that main branch or something like that. But then once this idea was done, then we did biomechanical testing. After that, we tested them in cadavers, and then we applied for permission from DGCA approval, DCGA approval. And once the government approval was done, then we, started marketing. The company started marketing, and I'm happy to share that I think roughly in last 6 months, it is 6 months since it became first available. Not many, but around 50 cases has been done in India. So surgeons keep on sending the pictures to me, and all the patients are doing well so far. So it is quite an exciting news for me, and it was quite an exciting journey for me for designing and implementation of this implant.
So,
Thanks.
how did you take it to the company? Did you exactly do a pitch before them, or since you were already quite famous and it was easy for you to talk to them, or is there any proper communication channel through which youngsters, can pitch their ideas to companies?
Actually, there was a casual talk over a cup of coffee. And when we were talking, and then I said that, the company looked very positive for supporting the innovations. That's what I understood while we were, sipping the coffee. And then I said, see, I have got this idea, and if you feel it is good, then we can work on it. And the beauty was that company said, why not? And the next day, the call was set on Zoom call was set, and then we discussed with their team, and then the ball started getting rolled. So there was no formal platform as far as I understand, but it was a casual talk. But I'm really appreciative of them that even on a casual talk, they picked it up and they supported.
The great things happen during casual talks. Because we
Yes, true,
can see
true,
in
true,
history.
true.
So it's nice to hear that already you got a lot of cases that is being done with the device, and it will be multiplying exponentially in the future. And the purpose of this podcast and showcasing this innovation is for everyone to know that such kind of device exists, and you do not struggle with your own techniques. It is already established, and it is there for you to just take it and use it and get it done in the right way possible, because it is already worked up, it has been approved, and it is showing good results. And it's all that's needed is to know the device and call for the person who is supplying it and get it done.
True.
So we are here to just support this innovation from our own leader, and we want this to be across the globe very, very soon, sir, across all the nations.
Thanks for supporting it.
Thanks, sir. We are reaching the end of the presentation. It was wonderful talking to you. I mean, we can talk to you for hours about your training and your, again, the 3D modeling for patellar biomechanics, etc. But that's for a different podcast, I guess. Thank you for, having, sharing your wonderful time and despite your busy schedule with us, sir.
Thank you very much. I really appreciate you guys looking for Indian innovators and asking them to talk and come to your platform. So it's really encouraging, and really it helps to, share your passion and your idea. So I loved it. Thank you very much.
Thank you, sir.
Thank you.